So, we're still talking about the nutritional support in our patients. In this section, we'll deal with the nutritional considerations. In the nutritional considerations, we'll talk about the enteral nutritional concentrations. Then, we'll deal with the macro and the micronutrient selections. And finally, we'll talk about the various access routes for TPN. So, starting off with the enteral nutritional concentrations, the enteral nutrition is safer and less expensive than parenteral nutrition, obviously. Now, the gastrointestinal tract can be used for the administration of complex nutrients that cannot be provided as readily intravenously as such as polypeptides and fibers. So the polypeptides and fibers, they cannot be administered into the bloodstream because they would not be absorbed. So these elements can be given readily into the gastrointestinal tract because from there they can be easily absorbed. The gut processing of many of these nutrients, it stimulates the hepatic protein synthesis. So they are interlinked. The gut processes these and it also stimulates the hepatic protein synthesis at the same time. Now, intravenous administration, it bypasses the portal circulation. So the portal circulation is being bypassed and hepatic protein synthesis does not take place in enteral total parenteral nutrition. Now, the enteral feedings, they afford significant local benefits on the mucosa itself. That is, when you're feeding the gut, enterally, the gut tube also derives a lot of benefits. The enterocytes are being fed directly, obviously. The absorptive surface of the mucosa is being stimulated and maintained. Now, the luminal nutrients such as the glutamine and short chain fatty acids, they are used by the small bowel enterocytes and colonocytes to as fuels. So, the enteral feeding not only helps maintain the enterocytes, they also provide fuel to the enterocytes and they also provide fuel to the hepatocytes themselves. So these are some of the positive aspects of the enteral feeding. Now, the trophic effects of luminal nutrition, the trophic effects of the luminal nutrition as well. They help to imbibe food into the bloodstream. They also cause absorption of various metabolites as well as the non-metabolites. They remain within the gut lumen and help form the feces. Now, moving on, the complex polypeptides and long-chain fatty acids, they stimulate the production of gut-derived immunoglobulin A, which is important in reducing the bacterial translocation. So, the enteral feeding also has an immunological component to it. That is, the long-chain fatty acids and complex polypeptide. They help in the secretion of immunoglobulin A, which reduces bacterial translocation. Now, the luminal nutrients also help maintain a normal pH and flora, thus diminishing the risk of opportunistic bacterial overgrowth in bowel. So the contents in the lumen, they're responsible for maintaining two things, the pH and the flora. And the maintenance of this pH and flora, this prevents the growth of opportunistic bacteria. Now, it is also safe because it's a physiological pathway and it has cost benefits because cheaply you can easily give nutrition to your patient and that comes off cheap. Now, these are the complications of enteral feeding. So, the complications of enteral feeding can be divided into access-related, functional, and metabolic. So, first of all, we'll talk about the access-related complications. The feeding tube can malposition, they can be clogging, and they can be accidental removal. So what is the cause? The feeding tube can be misplaced in the tracheobronchial tree because of their close proximity. It can become clogged with dense tube feedings or inadequately crushed medication or be accidentally removed. So we know whenever you're feeding your patient enterally, you should always maintain a clean, healthy tube. You should always keep the patient in either reverse Trendelenburg or at 45 degrees with the bed so that the patient does not aspire on it. And the tube should always be tied with the nasal prong so that so that the patient does not accidentally remove it. Now, the oro or nasogastric or enteral tube perforation of proximal gastrointestinal tract or the tracheobronchial tree. So, if at first you're in the wrong place and then you're pushing again and again, it can lead to perforation because it's a tube. So, the accidental puncture of wall of the structure by the feeding tube, where the feeding tube is being placed into, so it can cause punctures. Now, pressure ulcer at the skin entry site in sinusitis. And how do they develop? Now, a foreign body is being constantly pressed against the healthy skin, and it increases the risk of bacterial colonization of the nasal passages. Now, these were the access related complications. Let's talk about the functional complications. So, nausea, vomiting, and abdominal distension can be seen. It is usually due to delayed gastric emptying. Now, we can have diarrhea. It is usually polyfactorial, but high protein content and high osmolarity of the enteral feeding are the most common culprits. So you should always maintain the dietary requirement. You should always calculate the dietary requirement and always give appropriate nutrition to the patient so that it is not bulky, not osmotically active, and does not contain a lot of protein, because all of these would go unabsorbed and would cause osmotic diarrhea. Then moving on, we can have metabolic abnormalities. The first and foremost are the electrolyte abnormalities, because when the central nutritional content is inadequate to cover the daily needs, these electrolyte abnormalities can take place. We can also have volume overload from excess sodium and water loading, typically in patients with pre-existing heart failure. So you have to control the volume in these patients as to how much water and sodium is being given to the patient. And finally, we can have hyperglycemia. It is less common than patients who are if we compare it with TPN, but it may manifest in patients with diabetes or impaired glucose tolerance, or can herald sepsis. Now, it can occur in these patients, but it is relatively more common with TPN. Now, how do we select the macro and the micronutrients? So, the macronutrients are the fuels for performance of the body. They are responsible for the replenishing of the glycogen stores. They help to rebuild the destroyed muscle proteins. Now, the micronutrients are the fuels for protection of the body. They replenish the phytonutrient stores and they rebuild the damaged muscle protein. So, you need to see what element you actually want your patient to achieve. Sometimes you give a standard formula, a standard TPN formula to your patient, a standard feeding formula to your patient. These standard formulas are rich in both the micro and the macronutrients, so that your patient might achieve might achieve a balanced diet. However, if there's special dietary requirements, if your patient requires special nutrient, you should look for it and add it to your patient's feeding so that your patient might recover early. Now let's talk about the access routes. So TPN should be administered through a central venous catheter. And why is that? A central venous catheter has a wide bore and it's an open tube, so it can so large volumes can be given easily. It is inserted in either subclavian or internal jugular. So subclavian or internal jugular are the most common sites for the central venous catheter. Now, peripherally inserted catheter devices are also present. They can be inserted in the veins of antecubital fossa, that is the elbow, Now each reaches the atriocaval junction. So the junction between the atria and the cava, that is where they reach finally, these peripheral inserted catheter devices. However, these peripherally inserted catheter devices need supervision, and they're difficult to place. They can also always be, they need to be placed either by a radiologist or someone with a lot of experience. And after that, the confirmation is very important. The central venous catheter is comparatively easy. It's commonly placed by internists, physicians in the critical care, surgeons, and you can give large voluminous fluids through them. Now let's compare the access routes, the central access route to the peripheral access route. So the central access route is easy to meet the nutritional needs because it's a wide bore cannula with an open tube. Now peripheral TPN, it is unable to meet the needs for calcium and phosphorus. Now these vessels, they are slightly tortuous, they are not very wide, so you cannot meet the standard needs. There are no limits on osmolarity because it's a central vessel. The maximum rate of calcium gluconate is 200 milligram per kg per decigram of the needs. Now this is important because the peripheral vessels are not very wide, and there's only a certain limit to the amount of nutrition you can give through them. In the central route, there is less risk of phlebitis. However, in the peripheral route, there's increased risk of phlebitis. Now, you can use a central route for long term. Then it may require general anesthesia for the placement of the central route because the patient might not be very the patient might not be helpful. The patient might resist your placing of the central venous catheter. Then there's greater risk of infection. It is because you're directly into the bloodstream. There's increased cost, obviously, because an internist or a surgeon has to place this, and there's careful monitoring. There's greater risk of mechanical injury and air embolism. So you can cause air to enter into the vessel, or there can be mechanical injury because it's a very sensitive area, and you can cause venous obstruction by thrombosis or the formation of clot around the foreign object. So these are some of the complications of the central route of the total parenteral nutrition. As for the peripheral route, the maximum percentage of dextrose that can be given is 12.5. It is usually used for a shorter term. There's less risk for catheter related infections. It has lower cost. There's less risk of mechanical injury, air embolism, and venous obstruction. So peripheral TPN is comparatively safer as compared to central TPN. So this was all about this section. In this section, we talked about the various routes, the various important aspects of enteral feeding, how the enteral feeding helps the body. Then we compared various routes of TPN. You should always remember that enteral feeding is preferred in patients. However, when they cannot compensate, when they cannot tolerate the enteral feeding, you should always go for TPN. And a quick assessment should be done whether to have a central TPN access or a peripheral TPN access. For further such lectures, keep watching sqadia.com.